PPIs should definitely not be deprescribed in patients who've had complicated peptic ulcer disease, usually a GI bleed. In those patients, we generally give twice daily PPI for like somewhere of 2 to 4 months. And after that, the PPI can be stepped down to once a day. But generally, we do not recommend discontinuing the PPI altogether. Now, there are special scenarios of ulcer bleeding, such as patients who develop a bleeding ulcer after a period that they took NSAIDs. Now, in that case, there is a clearly identified cause, and if the ulcer is healed and adequately treated and the NSAIDs can be stopped, there probably is no need to give this patient long-term. Now, there is a special situation where people had a bleeding ulcer and were also Helicobacter pylori positive. So the Helicobacter, of course, needs to be treated, but it's very important that PPIs are not stopped in these types of patients until you're absolutely certain that the Helicobacter has been adequately cured. And the reason I say that is because there's good evidence also from clinical trials that if you have an H. pylori positive duodenal or gastric ulcer, and you were treated, but unfortunately the Helicobacter treatment failed, that there's a high likelihood that over the ensuing months, patients come back again with an ulcer, and again, often an ulcer that then will rebleed. So in H. pylori positive bleeding ulcers, don't stop the PPI or consider stopping the PPI unless you're absolutely certain that the Helicobacter was cured. And then finally, I will say, particularly in elderly patients, of which we have many, who are, for example, on anticoagulation and antiplatelet agents together for cardiovascular prophylaxis, and patients who may have other comorbidities in addition to that, I personally feel that you should have a low threshold keeping such patients on once daily maintenance PPI indefinitely.